Thank you so much, Vic. It was incredibly moving and honest and raw, and we appreciate your openness. I think about some of the themes that you highlighted over the last, couple minutes of openness, community, courage, and finding joy in other things that are not drugs. Thank you. Very profound.
Thank you.
All right, I think we all need a few breaths to kind of collect ourselves from that really moving testimony. We are going to switch gears a little bit to provide some programmatic updates on CHoSEN. And so I'll start with the data update on the quality improvement effort. Jaime Cabrera from CHoSEN QIC will provide an update around funding. And then Jade Woodard from Illuminate Colorado will provide some policy and multi-system updates. All right, I think we're going to do screen share here and in presentation mode.
My computer is still waking up. I'm sorry for the the delay between clicking the button and it happening.
Oh, great. All right. So I'll start off as I normally do for these forums to provide a data update. And so this is data from the second quarter of 2017 to the most recent quarter. And so this includes data on 1,237 opioid exposed newborns. Next slide. Oh, wait, before you move on, always have to highlight Blair Weichel, who is our fabulous data analyst, who handles all of our data for our quality collaborative. Next slide. Shown here is our key driver diagram for our effort. As you well know by now, we have really focused on 4 drivers for this hospital-based effort. The first was to increase and improve participation of Colorado birthing hospitals in our effort. Second was to reduce postnatal exposure to opiates, and this was really focused on optimizing non-farm care of withdrawal, and then using our ESC assessment tool. Third was focused on increasing family involvement, trying to engage prenatal counselors so that we could increase prenatal counseling. And then lastly, to improve the discharge process related to the plans of safe care. Next slide. We have brief data on our maternal sociodemographics. This is race, ethnicity, and insurance data. On the upper left, you can see race data, white, other, or missing. You can see that 2/3 of our mothers in our data set are white. 8% are other, and then we have about 1/4 that are still missing or unknown. As you know, as I've spoken of many, many times, race ethnicity data from electronic medical records has significant limitations with missingness as well as error. And this continues to be a problem for this effort, but I think also for other quality improvement efforts in our state. In terms of ethnicity, we see that 29% of our mothers are of Hispanic ethnicity, 2/3 are non-Hispanic, and then we have 9% missing. With respect to insurance, the majority, nearly 90% of our mothers are publicly or Medicaid insured. Next slide. This is one of our primary outcomes. This is looking at, oh, I take that back. This is, I thought this was going to be length of stay, but this is, we're actually looking at the percentage of mothers with medication-assisted treatment over time. Now, this is the most liberal definition of MAT. So this is sort of best case scenario, folks, because we define MAT as any record of there being methadone, buprenorphine, Suboxone use during pregnancy. And so you can imagine that there could be a record of it, but by the time that mother has delivered, there may not be active treatment going on. That being said, we are seeing some increases. When we first started, it was about at 45% of our mothers in our cohort had some documentation of MAT, and most recently we're about 61%. Again, I think this is sort of best case scenario because we also know when we do a deeper dive on the data, even among those women that are engaged in MAT, 50% of those mothers who are on MAT are also using illicit substances. So again, I take this, and I hope you will as well with a grain of salt. Next slide. This is one of our primary outcomes, which is length of stay of our opioid exposed newborns. This includes almost 1,000 infants, gestational age of greater than or equal to 35 weeks who have no other diagnosis that would impact their length of stay. And you can see that our mean was about 2 weeks when we started, and most recently we're under a week at 6.5 days. Now, you may recall that during the spring forum, I expressed concern that during the COVID time, we were seeing our trends going in the opposite direction. And in fact, we are coming back down, where in the winter of 2020, we peaked at 9 days of length of stay, and we are seeing again a downward trend. Next slide. Here we have the percentage of opioid exposed newborns who received pharmacologic therapy. When we first started, we were close to 60%, or a mean of 55 of our opioid exposed newborns required morphine or methadone. And then we came to a low of about 16%. I was again fearful during COVID that we were going in the wrong direction. And we were when we peaked at about 27% at the end of 2020. And then most recent quarter, we're down to about 18%. Next slide. Here we see the length of stay among those who received pharmacologic therapy, a very similar trend where we saw a nice decrease when our effort first started from about 3 weeks to about less than 2 weeks. And then again, during the COVID time peaked at close to 20 days. And then on the most recent quarter, we have come back down. Next slide. Here we have the percentage of opioid exposed newborns that are eligible to receive mother's breast milk and who are discharged to biologic parents. So we wanted to clearly define which infants would actually be eligible to receive mother's breast milk to get an accurate assessment of whether or not breastfeeding was happening and improving over time. And so here we are seeing, some variability, a lot of noise, because I think, our confidence bounds change, but in general, we have not seen a significant change from our baseline mean of about 44% of our mothers who are eligible to provide their breast milk. Now, what does that tell us? That tells us that if we look at the criteria for not being able to provide milk, that is still prevalent. That would be active illicit substance use, not having custody of your children, and or there might be other drug use that has not been within a 2-week interval period of abstinence. Next slide. So this is showing among those infants that are eligible to receive mother's own milk, what percent actually do. And so we have this odd data point at the end of 2017 where that percentage was very low. I don't know what to even do with that. That being said, in general, Colorado has very high breastfeeding rates for the general population. That also has been true for this population as well. But I would say in the recent quarters, we are seeing a decrease where we peaked at close to 90% and we're coming down to about 60 to 70%. And this certainly requires some additional investigation because study after study has already shown us that a mother's ability and support to provide her own milk can be hugely impactful in her recovery moving forward. Next slide. This I'm getting excited about. So as you know, while we are a hospital-based effort, we are trying our best to optimize our transition homeward. And so as part of that checklist of what does quote unquote optimal transition home or discharge look like, one is having a referral to early intervention in place prior to discharge. And you can see that when we first started, our baseline mean was 22%. We had a shift in the mean that was statistically significant up to 44%. And then most recently, we're close to 54%. So still a lot of work that needs to be done, but a twofold increase in our EI referrals. So I'm very excited about that. Next slide. This, however, I am very sad about. This is the percentage of opioid exposed newborns whose mothers received antenatal counseling. And so when we first started, it was close to 0 at 2%. We peaked at about 20%. And then, and most recently, I think COVID had a big factor certainly to do with it. We're down to 0. Now, I suspect this number is low to begin with, but part of it is also a data collection, data abstraction issue. If these prenatal consultations, in fact, are happening, we can't find them in the electronic medical record. So data and the transmission of data across the perinatal period continues to be a struggle. But don't get me wrong, this number is still very, very low. It may not be 0, but it's still extremely low. And that's why, as you'll hear today, there's a lot of effort being placed in that prenatal period. Next slide. Here we have the percentage of opioid exposed newborns that have received a handoff to a primary care physician for that infant. As I've said, repeatedly, we don't have really good data post-discharge, and therefore the very least that I would hope we could do is to have a verbal handoff or a warm handoff to that outpatient provider that will be taking care of this very high-risk family. We started off with a mean baseline of about 16%. We did have a shift that was statistically significant in the mean to 25%, still far from optimal. And then recently, a decrement that we noticed during COVID. And I'm not quite sure what to do with the extreme amount of variability more recently, but all I can say is that 25–30% is far, far from optimal. And so there are efforts within our CHoSEN QIC steering committee to really engage with the outpatient providers to better understand how we could support their education, but also support how they care for these infants and their families. Next slide. So this was just hot off the press. So Blair Weichel, our fantastic analyst, first authored this paper that literally just came out this week, focused on ethnic disparities in the care of opioid-exposed newborns in Colorado. Next slide. And so shown here are the average length of stay for opioid-exposed newborns. The upper graph shows the Hispanic group, and the lower graph shows the non-Hispanic group. What you'll note is that both groups do reach improvement, meaning a decrease in the average length of stay from about 2 weeks down to about a week. But notice how much longer it takes the Hispanic infants to experience this decline. Nearly a year, from 2018 all the way to 2019 is the time that it takes for them to see that shift in the mean, compared to our non-Hispanic group, which it happens in a quarter, from first quarter of 2018 to the second quarter of 2018. And so what we hypothesize perhaps is driving this is perhaps language, our ability to engage with our Hispanic families as effectively as we do with the non-Hispanic, but still there's a lot of work that we need to do to tease this apart and then to address this inequity. Next slide. Blair also demonstrated that there was a difference at the time it took for the decrease in pharmacologic therapy. So again, on the upper graph are Hispanic infants and their need for pharmacologic therapy compared to the lower graph, which is the non-Hispanic group. The Hispanic group takes 2 quarters, almost 6 months, to see a decline in the need for pharm therapy from about 45% down to about 30%. For the non-Hispanic group, again, this happens in 1 quarter from 54% down to 24%. And so while CHoSEN QIC was not developed at the outset with a health equity framework, we've learned so much that we've got to stratify our data to understand if disparities exist and if we're making them worse through our effort. Next slide. Now I'm going to hand it over to Jaime to provide an update about the work of CPC/QC.
Thank you, Susan. Hi, everyone. Thank you for having us here today, and thanks for being here. I just want to share a few updates on really some positive news that there is more funding that will continue to come both from the federal legislation that's been passing, if you're following some of the latest updates, specifically funding behavioral health, funding that's coming through our state and partnerships. And so just wanting to share how that will continue to support the great work that you are all doing in your hospitals and in your communities. We will continue to be funded for the Alliance for Innovation on Maternal Health, Substance Use Disorder Learning Collaborative. And that collaborative, I see some familiar faces here, folks that are participating with their hospitals in both this collaborative, which focuses on labor and delivery and comprehensive screening for behavioral health like anxiety, depression, substance use, intimate partner violence, and a number of other things on admission for delivery, and really thinking about how that links to projects like CHoSEN QIC and identifying substance use, hopefully prenatally, and then certainly at the minimum screening again when the person shows up for delivery, and then identifying any additional needs for caring for the newborn. And then, as Susan mentioned, really linking that care postpartumly, both for the mother and for the infant as they're discharged, making warm handoffs and referrals for continued treatment, as we have seen in the data, unfortunately, that a lot of negative outcomes and morbidity and mortality occurs within that 12-month period postpartumly. So we will continue to add hospitals, expand that work both on labor and delivery and NICU units. We continue to support the maternal mental health framework and collaboratives work across the state. We are launching in partnership with the CU School of Medicine, the NICU focus on engaging families called Define. And obviously with Dr. Susan Hwang behind that effort and leading that as a champion, we hope to really expand that work and grow that across the state as well, with certainly a focus on elements there of behavioral supports that are needed for the family when they have an infant in the NICU, looking at social supports, food access, transportation, mental health screening for both the pregnant, postpartum, father, spouse, or partner, and thinking about long-term care for infants that have been in the NICU. So a lot of work happening there. And then I'll dive in just a bit more to the pregnant and postpartum intervention pilot that the state is leading. And just want to make one note before we leave this slide. All of these programs have a goal to integrate families. And that is front and center as we go through these CHoSEN forums and as we think about all the project work happening both for pregnant, postpartum people and infants. And we have received additional funding from the Alliance for Innovation on Maternal Health that's funded through HRSA and ACOG. To launch our Family Integration to Restore Trust program, or our first program. And so we're really proud of that, where we intend to engage patients as partners in all of this work at all levels of the projects and the organization itself. So you'll continue to see those patient partners in all of the work that we're doing and embedded in these projects, and all decision-making and strategy as we think about continued partnerships for specific focuses on behavioral health in the perinatal period. So to dive in and just give you a little bit more information, so hopefully your interest is piqued and you might consider becoming involved in this program as the pilot expands over the next 18 to 24 months. We are partnering with the Department of Human Services Office of Behavioral Health, Gender Responsive Services, and really trying to develop a care network that really bridges the gaps in the perinatal behavioral health care that we're seeing, and not reinvent the wheel, but really connect all of the great work that's happening across the state, whether it's community-based or hospital-based or set in the outpatient ambulatory setting, so that we can have patient-facing care navigation and coordination, so that families are really engaged in the care, and that we're linking care, identifying access to this care early. That would include screening. It may include medication-assisted treatment launched in labor and delivery units and hospitals. We're talking to folks who've done this, whether it's in a hospital setting, employing a care navigator or coordinator to be that elbow-to-elbow support for patients and their families, or whether it be a community-based peer support specialist. So we're looking at an array of solutions and looking to work with certain communities across Colorado and specific regions to pilot what this comprehensive perinatal healthcare framework could look like by linking all of the work that's happening, and then hopefully bolstering that a little bit as well with some of this funding from the state. And then we hope to expand that across the state to other regions in the next 18 to 24 months and continue to grow that work. So we've been reaching out to some of you. I again see some familiar faces and names here to see what your community-based organizations and what your hospitals and what your ambulatory clinics are doing, so that we can take best practices and really try to leverage that as we roll this pilot out in the next year. So look for more information on that. And just to reiterate, I think the really encouraging thing here is continued partnerships, as Susan mentioned, with the organizations that you see here today, and many who aren't, but are doing really great work as boots on the ground, community-based organizations as well, and getting funds in the hands of the people doing the work. And so a lot of this work with the state is really leveraging the CU's Practice Innovation Program to focus the ambulatory outpatient clinics, prenatally and postpartumly, and pediatric and to also really work with the Colorado Center for Advancement of Patient Safety, which many of you know as an arm of the Colorado Hospital Association, as they continue to expand implementation of medication-assisted treatment programs in hospital settings. With Illuminate Colorado, who we all know very well, as we continue to think about the Circle of Parents, Bloom Yoga, and other really innovative ways that peers can support each other and families can get connected in their own communities with support and education. And then some additional contractors that we would leverage to really, like I mentioned, be the boots on the ground and implement these services in these selected communities for this particular funding source. So again, really looking to get funds in the hands of the people who are doing the really great work across the state, and then take those best practices that are working well and expand those statewide so that we can continue to create a true continuum of perinatal behavioral health care. So that's really it. Just again, wanting to encourage everyone that this is a priority for both our federal government, our local government, and organizations represented here today and also not here today, to really be committed to collaborate and continue to expand work in this really important space. And with that, I will turn things over to Jade from Illuminate Colorado.
Good morning, everyone. Thank you, Jamie. Thank you, Susan. I'm always so grateful and inspired to be here with you all and to hear about all the amazing work that you're doing and share a little bit of our piece. So a few updates here that I'll provide are really continuing updates around systems change efforts and policy. So the first one is, as many of you recall, we've been working on a change in the Colorado Children's Code. So that is the piece of state law that dictates child welfare involvement. So back in the 2020 legislative session, we made a change to the language there around prenatal substance exposure. And over the last couple of years, that has been going through rulemaking processes to ensure that the state is implementing that in alignment with the language from the change in statute. So that rulemaking has been underway. And then in addition, plans of safe care rulemaking is underway. And so again, I know we are all very familiar with plans of safe care, but the state is really through the Colorado Department of Human Services looking at how does the child welfare system respond to requirements for plans of safe care. And so that rulemaking is really tailored and narrow to when a family is reported to and screened into the child welfare system, what are child welfare rules that must be followed. So myself and Dr. Bruns are participating in that, and actually have participated in both of these different rulemaking sessions. And I believe there are a handful of different listening opportunities if you'd like to have an opportunity to share more or learn more about those rules. In addition, we've been working on implementing pieces of legislation from last legislative session in 2021 or this year. And so that includes the Behavioral Health Recovery Act, the Birth Equity Bill package, and then peer support professionals. And so really looking at how are we supporting and informing those pieces of legislation and how that is interfacing with families impacted by substance use during pregnancy. Organizationally, we're continuing to work on Illuminating Childcare, which is our childcare program for families seeking substance use disorder treatment, as well as our Circle of Parents in Recovery expansion, including a randomized control trial on that program, and then different educational and resources for both providers and parents. I think I saw Dr. Halmo on here has been helping with some of our toxicology pieces, but continuing program implementation in those areas. On a bigger picture level, wanted to make sure everyone was aware of some changes happening around, or maybe changes isn't the right word, but some movement happening around our opioid settlement dollars. So Colorado is slated to receive 18 years worth of payouts from multiple opioid settlements that are all being managed through the Attorney General's office. And again, these are the result of lawsuits against primarily manufacturers and the settlements that have come out of those. The opioid settlement funds are being really administered through regional bodies that are helping to get those out into communities and are setting local priorities. So if you are interested in that, there is an entire regional opioid oversight committee. The Attorney General's office is leading the work. We've been really involved. The Substance Exposed Newborn Steering Committee actually submitted a list of potential things that communities could consider investing in locally if they had resources and wanted to address this issue but didn't know how, which included many of the priorities that we've all spoke of. And then the last one is the behavioral health, so federal stimulus dollars through both the CARES Act as well as ARPA, the American Rescue Plan Act, are all getting invested right now. And the new Behavioral Health Administration has been seeking input and information on different ways that they could be investing those resources across our state. That has been really informed by much of the work that has been done through you all and in your local areas, but also through these kind of opportunities when we're all able to come and convene and learn from each other. So the next slide. Also just wanted to remind everyone that the Substance Exposed Newborn Steering Committee, which is really a collaborative of multiple different both healthcare and medical providers, as well as human service and community-based organizations, families, have set their new priorities for 2021-2022. So you'll see them here on the screen, really very strong focus on reducing stigma. And we're doing that through two of our work groups, the Provider Education Work Group, as well as our Family Advisory Board. The second one is really around systems, ensuring that systems have policies and practices in place that support warm handoffs. That's really where we're doing much of our plans of safe care work, as well as supporting all of your work here. The third priority is around our statewide capacity to align efforts, really focus on being data-driven and responding to emerging needs. And so that's where we've done some work around the opioid settlement funds that I was mentioning, and where we engage in policy, data, and research. And then finally, we're continuing to focus around fetal alcohol spectrum disorders in specific. So if you're interested in any of these areas, if anything here is piquing your interest, please reach out. Cassie put the information in the chat. We'd love to get you connected to be able to dig in even deeper in some of these different focuses. So I think with that, I'll turn it back over to Susan, and thank you all. Happy to be here.